Equals, it's Kim. And here on Kim Perfect TV, I talk about LGBT issues, lesbian, gay, bisexual, and transgender issues, particularly about those issues in the state of Ohio, but not always. Sometimes we talk about national issues. And often the issues in Ohio are also national issues. So if you're interested in that kind of thing, stick around. You might want to subscribe and hit the little bell so that you get notified every time I put up a new one. And for the last week or so, we've been talking about LGBT youth. And we're going to continue that theme today. And today I'm going to talk about what I know. And granted, this is not an area where I have a lot of expertise, but I happen to have gotten an education a little bit earlier this week around the issues of minor children and receiving treatment for gender dysphoria. A few things. Gender dysphoria is right now, is a mental health diagnosis that really can only be diagnosed by a mental health professional. So the idea that anybody else could diagnose gender dysphoria or symptoms of gender dysphoria is suspect. And that is, and we've been kind of talking about these issues around House Bill 658 in Ohio, which deals with a parent's rights to not only make decisions, medical decisions for their child, but also to know that their child exhibits symptoms and requires, government agencies, etc., including school teachers and sometimes medical professionals, to out a child to a parent. And this is where it gets highly problematic. So anyway, what did I learn this week? Well, I learned that there are kind of two different approaches to treatment of minors who are diagnosed with gender dysphoria. And just for those of you who don't know, gender dysphoria is this kind of feeling in the brain that's persistent, insistent, and consistent, persistent, insistent, and consistent, and not just a passing fad, that the person doesn't identify with the gender that they were assigned at birth, which was by a doctor based solely on a visual look at genitalia. Medically suspect to start with. Anyway, so it's this inconsistency in their brain. A couple years ago, a trans woman that I know well and that I trust used the following metaphor that might be helpful. For those of you who are familiar with how Ritalin works, Ritalin, when you use it with somebody who has ADHD, so this is, a brain chemistry disorder, who has ADHD, it will calm them down. They respond to the drug differently than other people, because if you gave the same drug to somebody who doesn't have ADHD, it's essentially speed, and it will speed them up. So hormone replacement therapy, or testosterone for a trans man or estrogen for a trans woman, acts similarly. Here's my metaphor, all right? In that when given the hormone that is consistent with the gender identity that the brain is telling the person they are, it calms down all their symptoms of gender dysphoria, makes them feel so much better in their bodies and in their brain, and it's noticeable for them. And it's one of the, I've heard other medical professionals say, one of the kind of final signs that somebody truly is transgender is if they do respond to the hormones in this way. Now, if you gave those hormones to somebody who is not transgender, the brain would it just would not work for them. Kind of like speed doesn't necessarily work for us. It makes us feel strange and weird, and in the same way. So that's kind of how you might want to think about this, is that medical treatment, hormone replacement therapy anyway, calms all of the dysphoria down. It is the treatment for gender dysphoria. Now, gender dysphoria can be experienced on a wide range, a continuum, if you will. And so some people have very severe gender dysphoria, some people have a very small amount of gender dysphoria, and so the need for the hormones may differ from person to person. And a person with some very severe gender dysphoria is the person that we might say something like that not getting the hormones that they need, calming down the brain, could be one factor in suicidation. Now, to say that a transgender person who doesn't get hormone replacement therapy is going to cause them to attempt suicide is not a good talking point, so to speak, because it's not true according to the education I got from trusted medical professionals. There are these two kind of different approaches to gender dysphoria, or to the treatment of gender dysphoria, and there's apparently also a spectrum here. So clinics might go for very much a psychiatric model, in which case there is a lot of therapy involved, there's psychiatric oversight, total well-being, psychiatric well-being of the young person is, I don't want to say that the others don't take it into account, but is given a priority that may not be given at another clinic. And that other clinic may be more from a medical model, where they are, they're more likely doctors or MDs instead of psychiatrists. And they're more likely to look at this gender dysphoria as a medical issue needing medication, namely either puberty blockers or hormone replacement therapy. We'll talk about puberty blockers here in a minute. Different clinics have different approaches. So what I've learned is that if a young person comes to, let's say, I learned mostly about the psychiatric model. I hope to learn more about the medical model later. The psychiatric model, if a young person comes and is indicating that they have gender dysphoria, they may not know the term, of course, but if the psychiatrist thinks they do, and they want to give that child a bit longer time to consider what they want to do, they may give the child puberty blockers. Now, puberty blockers have been used for decades. When puberty is functioning in a way that is not conducive to the development of a child. It has more recently begun to be used with children who may be have gender dysphoria. Now, what a puberty blocker does, let me go back. So according to the expert that I was talking to, they will allow a child to go into puberty a little ways, because if they truly have gender dysphoria, that puberty will cause the gender dysphoria to get worse. Medical professionals will want to see how the child reacts to puberty, so they'll allow puberty to go forward for a short period of time. So a medical doctor will allow a child to go into puberty for a little while, see how they react to it, and if, in their medical opinion, that the puberty blockers would assist the child to buy them more time, they will give them puberty blockers. What's the upside of giving a child puberty blockers? Well, like we mentioned, it postpones the irreversible body changes that happen at puberty. By irreversible, meaning that it would take surgery to correct them. The development of a beard, the development of breast tissue, those kinds of puberty events. I'm not a doctor, I don't know the event, but the ones that, if you wait until later in life, require invasive surgery. And so it buys the child time. And if, when they get to be 14, 16, 18, the child decides, yes, they definitely do want to continue transition, then they might be able to do so without a lot of the surgeries that somebody who goes through puberty would have to undergo or might choose to undergo. Downside, I understand, is that, there might be brain development issues. Don't know. I would talk to a medical professional. And also some tissue development. If you don't go through puberty, let's just face it, if you don't go through puberty, a penis doesn't develop to the size that it would, and because gender confirmation surgery in a trans woman involves taking tissue from the penis and creating a vagina from it, that there may not be enough of that tissue. So that is, what I understand, one of the downsides. And these are things that parents and the child would discuss with their medical professional. These kinds of decisions should be made by the parents and guardians, the child, and their medical professional. That gets a little sticky because which parents? Because sometimes we all know that in some family dynamics, parents are playing each other, using a child to play against each other, that they've got a grudge against the other parent. We've seen this in divorce situations. And so they're using the child as a weapon against the other parent. Things happen. So becomes this question of, which parents, how many parents? What about the parent in jail? What about the parent who's never been part of this child's life? What about the parent who only sees is involved with the child, but only sees them a few times a year? From what I understand from the medical professional I was talking about, certainly from a psychiatric approach, they are making these kinds of decisions on a case-by-case basis, taking into account the whole health of the child. So while a parent who has never been involved with a child's life might be dealt with in one way, a parent who is involved with the child's life but doesn't see the child that often might be considered in a different light. So all of this is kind of a case-by-case situation right now, probably as it should be. Then what about hormone replacement therapy? We really didn't get too much into this, but I did hear that for a number of years that hormone replacement therapy wasn't something you considered doing until a child got to be about 16. I do understand that age has dropped somewhat, down to 14 in some cases. Again, the doctors say that they need to make these decisions on a case-by-case basis based on the maturity, the cognitive maturity of the particular child in question. And I really do believe that the case by case, especially with transitioning, is how this should be done, because everybody transitions differently. No two transitions are the same. And again, I'm cisgender. I have not been through this. I am just communicating what I did learn from some medical professionals earlier this week. So that House Bill 658 does a number of things. One of it is trying to say that all parents, regardless of the situation, have to give consent for medical treatment, and that medical treatment isn't actually totally defined and includes not only puberty blockers and hormone replacement therapy, but also social therapy. So the idea that for a child to socially transition, this means without any medical intervention, that they may change their name, they may go by different pronouns, they may use gendered spaces that are consistent with their gender identity, but they're not receiving any medical treatment. And so HB 160 includes that kind of therapy, for lack of a better word, or approach to helping a child transition, or at least experiment with transitioning to see if it calms down their gender dysphoria. So it's problematic in that doesn't allow for this kind of case-by-case basis. In an ideal world where a child had two affirming parents, that were married to each other, that got along, that functioned as mature adults, maybe this would be okay. But that's not the way the real world works. And so a case-by-case basis, based on the medical professionals' knowledge and expertise, should be the deciding factor. Now, the other thing that HB 658 does is, of course, require outing children. What we were hearing from the experts is this goes totally against HIPAA. It goes against a medical professional's desire to help and not hurt. We all know that sometimes if you were to out a child to a parent or guardian, you could put that child at even more risk. Refer back to some of my earlier videos if you'd like to learn more about them, and I'll try to link them above. Not a good idea. I was talking to social workers, and the social workers were saying, yes, they cannot it's against their ethics, their standards of care, to out a child to a parent who may be hostile, and that they couldn't do it. So we're talking about a lot of felonies being charged against healthcare providers, whether they're social workers, whether they're doctors, whether they're psychiatrists. And what about the school counselor? In developing a relationship of trust with a child, to break that trust by outing the child to parents that the child knows will not respond well, that's why they haven't come out to them themselves, just could destroy not only the child's trust in that particular healthcare provider or trusted adult, but their trust in any adult around these kinds of issues. That may be an over-exaggeration, may not be. Anyway, that's it for this week. If I'd love to have comments or questions below. We can further the conversation from there. Again, not such an expert here. I did just kind of get an education this week, and I thought I'd share it with you. Give me a thumbs up if you enjoyed this. Hit the red subscribe button. Hit the little bell so that you get notified every time I put up a new video. Have a great week, equals. See you later.